Hey everyone, and welcome. If you're a nursing student getting ready for the NCLEX, or a nurse who just wants to really sharpen those pediatric skills, you are in the exact right place. This is a special study guide edition, and we're about to do a deep dive into pediatric respiratory conditions, breaking down everything you absolutely need to know for your exams and, even more importantly, for your patients. So here's our game plan. We're going to start from the ground up with the unique anatomy of a child's airway. Then we'll get into the weeds of chronic conditions like asthma and cystic fibrosis. After that, we'll tackle those acute, scary emergencies you'll see in the ED. We'll wrap it all up with some seriously powerful NCLEX tips and a clinical challenge to put it all together. Sound good? Let's get started. All right, first things first, let's talk about the golden rule of pediatric nursing. Children are not just tiny adults. And this is never more true than when we're talking about their airway. Seriously, a few millimeters of difference here can be the difference between life and death. And get this isn't just about a few sniffles. Respiratory illness is the #1 reason kids get admitted to the hospital. A child can look fine one minute and be in serious trouble the next. That's why your assessment skills have to be laser-focused every single time. So what is it that makes their airways so different? Well, it really boils down to 4 key things. For starters, their tongue is massive compared to the size of their mouth, so it can fall back and block everything pretty easily. They also have bigger tonsils and adenoids just hanging out back there. But honestly, the real game changers are the airway itself. It's just so much narrower, and the fact that they are born with way fewer alveoli. You know, those little air sacs where all the magic of gas exchange happens? Okay, so what does all that anatomy stuff actually mean at the bedside? Well, that tiny airway means a little bit of swelling, something you or I wouldn't even notice, can cause a major blockage in a kid. And with fewer alveoli, they have to breathe faster just to get enough oxygen in. That's why their baseline respiratory rate is so much higher than in adults. They're already working harder, which means they have basically zero reserves when things start to go south. Okay, now that we get just how fragile that pediatric airway is, let's see how it all plays out in 2 of the most common chronic conditions you're going to manage: asthma and cystic fibrosis. We're moving down from the throat and into the lower airways. So let's talk about asthma. It's the most common chronic illness in childhood. Now, it's easy to just think of it as tight airways, but it's really a 3-part problem. First, the airways are hyperresponsive, meaning they totally overreact to triggers. Second, you get edema or swelling. And third, they produce a ton of mucus. It's that trifecta of trouble that makes it so hard to breathe. So picture this. This is what happens during an asthma attack. It all starts with the trigger. Could be dust, pollen, a virus, you name it. That kicks off this crazy inflammatory response, which leads to all that swelling and thick mucus. Then the muscles around the airways just clamp down, and that traps air inside the lungs. That trapped air is exactly what causes that classic wheezing sound you hear when they try to breathe out. Okay, lean in for this one, because this is a critical safety point for your exams and for your practice. You absolutely have to know the difference between rescue meds and maintenance meds. Rescue meds, like albuterol, are for right now. They're for emergencies. They open up the airways immediately. Maintenance meds, like an inhaled steroid, are for prevention. They work on that underlying inflammation to stop attacks from even happening. Confusing these two is a really common and dangerous mistake, which is why patient teaching on this is so important. Now, let's switch gears to cystic fibrosis. And wow, just look at this picture. On the left, you've got healthy, open airways. But on the right, that's the lung of a child with CF. The airways are just completely clogged with this thick, sticky mucus. And that's the core problem of CF. It's not just a lung disease. It's a disease where the body makes abnormally thick mucus everywhere. And because CF affects all the mucus-producing glands, you see symptoms all over the body. A parent might be the first to notice that their baby's skin tastes really salty when they kiss them. But the GI symptoms are a huge clue. Poor weight gain, and these big, greasy, awful-smelling stools. And you know why? It's because that same thick mucus that's clogging the lungs is also blocking the pancreas. So digestive enzymes can't get out to break down fat. That leads to malnutrition, which just weakens the body and makes them even more likely to get those chronic lung infections that are the hallmark of the disease. So as the nurse, your care plan has to hit both problems at the same time. For the GI side, you're going to give pancreatic enzymes with every single meal and every single snack. It's non-negotiable if they're going to absorb any nutrients. They need a diet that's super high in calories and protein to fight that malabsorption. And then for the lungs, it is all about airway clearance. That means chest physiotherapy. Yep, you're literally percussing their chest to shake that mucus loose multiple times a day, usually paired with inhaled meds to help thin everything out. Okay, let's move up from the lower airways and talk about the upper airway. Now we're dealing with acute problems, where you have to think fast and you have to be right. Getting this wrong can have devastating consequences. So let's start with a really common complaint, a sore throat. Take a look at this picture. This is a textbook case of strep throat. You see that angry red color and those white spots on the tonsils? Those are huge telltale signs of a bacterial infection. But your first job is to figure out if you're dealing with a virus or bacteria. A viral sore throat usually kind of creeps up on you slowly. Bacterial strep, on the other hand, hits like a truck, abrupt, high fever, and that classic-looking throat. This is the one that needs a full 10-day course of antibiotics to prevent some really serious complications, like rheumatic fever. And here's a key teaching point for parents. Have them toss the kid's toothbrush 24 hours after they start antibiotics to keep them from getting reinfected. All right, now for two conditions you absolutely, positively cannot mix up: croup and epiglottitis. Croup is viral, and you'll know it by that crazy, unmistakable barking, seal-like cough. The child with epiglottitis, though, it's bacterial, they look terrifyingly sick, and there's no cough. Instead, the key signs are drooling and being unable to swallow. If you see a child drooling instead of coughing, every alarm bell in your head should be going off. Let me just be crystal clear about this. Epiglottitis is a true, life-threatening medical emergency. This is not a let's watch and wait kind of situation. The epiglottis, that little flap that protects the airway, swells up so much that it can literally slam the door shut on the windpipe, completely cutting off their air supply in minutes. Okay, because epiglottitis is so incredibly dangerous and you have to act so fast, you need a quick way to recognize it. So let's lock in some memory tools that are going to help you spot it and know exactly what to do, and, just as importantly, what not to do. Here it is. This is a memory anchor that could literally save a life. The second you even think you might be seeing epiglottitis, I want you to remember the 4 Ds. This is going to help you instantly recognize this emergency. So let's run through them. Dysphonia, that means their voice sounds really muffled or hoarse, kind of like they're talking with a hot potato in their mouth. Dysphagia, that's difficulty swallowing. It hurts way too much, which leads directly to the next D, drooling, because they can't even swallow their own spit. And finally, distress. They are clearly, obviously, struggling to breathe. And look for that bonus sign, the tripod position, where they're leaning forward on their hands, just trying desperately to open up their airway to get more air in. Okay, if you remember absolutely nothing else about epiglottitis, please remember this. Do not upset the child. I'm serious. No IV starts, no oral temps, and for the love of all that is holy, do not stick a tongue depressor in their mouth to take a look. Why? Because making them cry or gag can trigger a laryngospasm, where their airway just slams shut. Your number one job is to keep them calm. So, what's your immediate action plan? First, get oxygen on them, but in the least threatening way possible. Even if it's just a parent holding the tubing near their face, that's better than nothing. Second, keep everyone and everything around them calm. Third, you notify the team immediately to get ready for an emergency intubation, and this is going to happen in the operating room, not at the bedside, where an anesthesiologist can secure the airway safely. Whew, okay, we have covered a ton of ground. Now, let's see how this all comes together in a real-life situation. It is time to put your clinical judgment to the ultimate test with a case scenario. So imagine this. You're the triage nurse in the ED. A parent rushes in carrying their 4-year-old. They tell you the child suddenly got a really high fever and a severe sore throat just a few hours ago. You look at the kid, they're sitting bolt upright, leaning forward on their hands. They're drooling, and from all the way across the room, you can hear this high-pitched sound every time they take a breath. Every single alarm bell in your head should be screaming right now. You are looking at the classic signs of epiglottitis. So based on everything we've just talked about, what is the very first thing you do? Not what you get ready to do, but what is your immediate number one priority action in this exact moment? Your next move is critical.